I invite the expert speaker, Dr. JINESH, to come to that. The senior topic is initial trauma management using compass. Dr. JINESH is the head of the Department of Emergency Medicine as well as KANNUR. Now, a few words about the expert speaker. He did MBBS from PGMC Medical College, LLP. They have training in emergency medicine under George Washington University at DMH Calicut. Worked in DMH Calicut and MIMS Calicut. Now he is working as HOD emergency medicine in MIMS KANNUR. So I invite Dr. JINESH to present me here.
Good evening, all. Thanks, Suresh, sir, for the kind words. Remember, Suresh, sir, from long back while I was doing my house residency, it was a UNIMS PG. Currently, I'm working as a consultant and head of the department in emergency department, MIMS KANNUR. Also be regional faculty for the American Heart Association as well as instructor for various life-saving courses. My intention basically was to talk on basic trauma management, especially for the new upcoming doctors who are not yet been into much of training in the initial response to trauma. We see a lot of death because of probably it's not because of lack of knowledge, but lack of experience and not knowing a proper way how to initially manage the trauma situation. By the time they reach the trauma centers as such, not many things would have been done which could have saved the patient. By the time they sometimes reach a point where there is no going back. So I'll be talking basically about why we are talking about this trauma management. What is the primary survey? Management of trauma in a primary setup. Some little bit about trauma, triad of death, but we have a lot of contribution, and regarding patient transport. So why are we talking about this? Trauma is the leading cause of mortality globally. Worldwide, road traffic accidents or injuries are the leading cause of death, especially in the young age group between 18 to 29. And it is responsible for a lot of death that it might become the leading cause of death by 2030. At least very few before them. Like at least the third position will be by trauma deaths. And it's also like mostly it's like penetrating trauma is only 15% of total deaths in areas where there are no conflicts. Death due to trauma is basically because of blood loss primarily. Later it can go on for multiple organ dysfunction and cardiopulmonary arrest. Earlier there was the golden hour concept, which basically changed the whole world of trauma management, where it was emphasized for the need of rapid intervention in the initial hours, the first hours following the trauma, And it has been proven that rapid interventions, especially in areas where there is an obstructed airway, trauma-related tension pneumothorax, severe hemorrhages, etc., but if we can manage it rapidly, the mortality will come down a lot. So what do we have with us to treat trauma in the initial setup? We all know about the famous ATLS protocol, and you know how it was developed. An orthopedic surgeon named James Steiner, while he was flying his private flight in Nebraska, he went into a crash. His wife died there, and he took his children along with him and was taken to a primary center where they were actually mismanaged. So he had a concept like if something could be done at the early stage itself, a lot of lives could be served, and from that developed the ATLS protocol for trauma management. It's nothing but our old ABCD6 itself. A, slightly different from the non-trauma management, where A stands for airway assessment and protection, along with cervical spine stabilization. I specifically say stabilization, not assessment. Breathing with ventilation assessment. Circulation comes with along with hemorrhage control, and disability assessment along with the neurological aspects, and exposure with environmental control. We'll go into each one of them in detail. Coming to airway, the most common cause of death immediately after severe head injury where they die immediately is basically because of airway obstruction, which can be caused either by tongue fall because of unconsciousness, because of some foreign body which has been which goes into the throat. It could be because of aspirated blood, food products, etc. Tissue edema in the laryngeal aspects, especially in blunt trauma of the neck, and also in the injury to the neck, there could be expanding hematomas which can compress on the airway and kill the patient. So how do we assess the airway? And what are we assessing for? Airway can be either patent, it could be maintainable, it could be threatened, and it could be completely obstructed. When you talk about patent airway, the easiest method to find whether the airway is patent is to talk to the patient. If they can talk, and if they can talk sensibly, it basically gives an idea about the whole ABCDs. If the patient can talk, understand what he is asked about, and he can reply properly, that means his airway is not obstructed. He has got enough reserve in his lungs to talk those words. He has got a sensorium is good enough to understand the question, give the answer, and for this he needs a proper cardiac control. So a quick assessment of the ABCDs can be done by talking to the patient itself. And after that, if the patient cannot talk, we can examine the airway to see whether that's threatened or weakened. When it is threatened, there could be abnormal sounds like gurgling sounds, snoring sounds. Okay, there could be stridor because of edema, etc., where the airway is threatened. It might be maintainable. Some situations, for example, if when you're sleeping, even if we don't talk, we understand that the airway is maintained because there is no respiratory distress at that point. And when it is completely obstructed, the patient will be in severe respiratory distress. Along with that, he will not be able to produce any sounds. Managing the airway at this stage is very important. There are so many methods to manage the airway. Basically, it could be by simple positioning, like jaw thrust and chin lifting. And if it is not maintainable by that, we can go for the other airway adjuncts. You can do the suctioning if there is no gurgling sound. If you can positioning if there is snoring sounds. If there is a stridor, we have to look for any foreign bodies, etc. Other methods like oropharyngeal airways, nasopharyngeal airways to maintain a proper airway. Few caveats there. When you use an oro, we have seen multiple times that oropharyngeal airway has been inserted into the throat of the child person who is still conscious or semi-conscious with an intact gag reflex. You should understand that an OPA, if you can maintain an OPA in your throat without any other sedation, that means his airway is not maintainable. It is threatened, and you need to have a definitive air. Similarly, we have seen nasopharyngeal airways inserted into those people with a suspected mesoskull fracture, especially in trauma. There are certain signs that we can look for understanding the mesoskull fracture, including battle sign, CSF otorrhea, rhinorrhea, etc. And they are strictly contraindicated. Once you put in the nasopharyngeal airway, it goes into the cranial cavity, and you start backmasking the patient later. The whole air will be pushed into the cranial cavity, causing severe pneumocephalus, and that can kill the patient immediately. It's not the infections or the bleeding that will kill. The pneumocephalus will kill the patient because of raised IC immediately. So when you're using adjuncts also, make sure that the patients, you examine the patient properly before doing that. Another thing that comes along with the airway management itself is C-spine protection. Various methods have been developed to protect the C-spine. It has to be assumed that any injury, any polytrauma patient, that cervical spine is injured and it has to be stabilized. There is no point in examining the patient who is unconscious or in severe trauma with the distracting injuries to understand whether there is a midline tenderness. So imagine that that patient has got a cervical spine injury and make sure that they are that is taken care of. But certain cases it is not necessary, especially with penetrating trauma, stab injuries, etc. And the patient is fully conscious. There is no point or there is no meaning in putting a hard cervical collar. And especially once you put a cervical collar, there are so many difficulties, especially in intubating the patient. You will have to remove the anterior part of the collar, give inline stabilization, and then manage the patient for intubation. After airway management, then comes the breathing and ventilation. Maintaining saturation, especially if the patient is losing blood and is going for shock. Maintaining proper oxygenation is the foremost important thing in trauma management. Start off with high flow oxygen as well as if the patient is in polytrauma, even if the saturation appears to be normal. And chest trauma accounts for about 20 to 25% of all trauma related deaths, especially in conditions like pneumothorax and massive hemothorax. The assessment is done by looking at the respiratory rate, looking at the saturation, assessing for the air entry, whether it's equal on both sides, if the chest rise is equal on both sides, if there is any paradoxical movement, and the work of breathing. Once you assess the respiratory system and you find that there are three things that you have to, the killers, I would say, are like tension pneumothorax, massive hemothorax, severe lung conditions, flail chest, etc. Make sure that that is managed immediately. There are various systems to deliver oxygen, low flow systems like nasal cannula, face mask, etc. High flow systems like non-rebreathable mask, bag mask ventilation, etc. that can be used to deliver oxygen. Beware of the killers, especially tension pneumothorax, massive hemothorax, cardiac tamponade. I'm including that because they are associated with chest trauma, flail chest, multiple lung conditions, and you can, if available, use an ultrasound to identify whether these are there. It can help you a lot, saving a lot of time. And if you find that a patient has got a tension pneumothorax, immediately put in its needle. Don't worry about it. You can put a chest tube later. You get some time. But that simple action of poking into the pleura, releasing the air will save a lot of patients. Then comes circulation. What are we assessing the circulation for? Basically to see any signs of shock. The most important thing is to, once you finish the airway and breathing, look at the circulation. See if the patient is in shock. You look at the heart rate and especially the periphery. Don't wait until the saturation falls to identify that the patient is in shock. If the peripheries are cold, if the peripheral pulses are feeble, understand that the patient is shocked and needs immediate resuscitation. Look at the mental status. If the patient is becoming drowsy, it need not always be because of a head injury. It can be because of decreased organ perfusion. It can be because of decreased cerebral perfusion that the patient is becoming drowsy or unconscious. And definitely you have to look at the blood pressure. One of the blood pressure is, do not depend always on your automatic blood pressure machines. Go back to your old manual blood pressure machines to identify whether the patient is hypertensive or not. I'll put the slide later. And whenever you see a patient in trauma, before transferring, make sure that you put in a large bore IV line. By the time they reach a trauma center, most often they have lost much of the blood and getting an intravenous access would be very difficult at that time. So as soon as the patient is trauma, make sure if possible to have at least 2 large bore IV cannulas, start with fluids immediately and send the patient. Later, if they might need blood and blood products, if the fluid resuscitation is not good enough. Where do you look for the bleeding? How do you identify it? Especially when I say that you need to have hemorrhage control along with resuscitation with fluids or blood. Unless you close the broken pipe, there is no point in pouring whatever you have into the bloodstream. So make sure that there is a little bit of, you do a hemorrhage control thing. So how do you identify where is it bleeding from? The easiest method to identify the source of bleeding is look at floor and foremost. Floor determines the external hemorrhage that you can see outside. Foremost are the cavities, the thoracic cavity, the abdominal cavity, the pelvic cavity, and the long bones. If you find that there is a long board, immediately put a splint before you shift the patient. It might not be easy to identify a bleeding inside the abdomen. Probably if you have an ultrasound, you can identify that. But otherwise, it might be difficult. But if you assume that the patient is in polytrauma, before you send the patient is in severe shock, have a pelvic binder. If you don't have a pelvic binder, at least take a bed sheet, tie up the pelvis at the level of the most common mistake that we have seen is they tie it at the level of the anterior superior iliac spine, where it actually opens the pelvis more. Instead of that, at the level of the greater triangle, tie it up and then send the patient to the trauma center. So if it is an external bleed, you can do direct manual pressure. And most common mistake again, don't take your hands off to see if the bleeding has stopped. Continue manual compression at least for 10 to 15 minutes. If it is not possible for that, especially if there is a protruding bone outside where you cannot give a direct compression, you can use a proximal compression. You can use at least your blood pressure, BP cuff, etc. Or you can use a tourniquet to give compression above the point of bleeding so that the bleeding stops. And again, elevation of limb. Usually the venous bleeding gets controlled by direct pressure. If you suspect that there is a pelvic bleeding, no need for any evidence. You suspect that there is a pelvic bleeding, immediately give a pelvic binder or at least tie it up with a bedsheet. There are various hemostatic agents available if none of these things works, especially in superficial wounds which is bleeding profusely. Medicated gauzes are available. You can pack it up and then send the patient to the necessary centers. Giving fluids. We have been taught about give fluids, and it always gives us some comfort when you see the blood pressure on the monitor normal. There is no need for that. As long as the peripheral pulses are felt, as long as the patient has enough sensorium, there is no point in increasing the BP to say that the patient is stable. Give fluids at the minimum. The current recommended amount of fluids to be given according to ATLS protocol is 1 liter. More than that, it's going to create a lot of issues later. And especially if you don't record that you have given only 1 liter. Sometimes we see that a lot of fluid is given and it's not recorded. And when they come to our center also, we start giving fluids again because we don't have any data regarding how much fluid has been given. So unnecessary infusion of crystalloids should be avoided. If you think that it needs more than 1 liter of fluid to resuscitate the patient, make sure you start with blood and product. The easiest one that you can do is to start with an O negative if available. Start with 2 PRBCs of O negative. That can save the patient's life a lot. And those with, if you keep on giving fluids, blood, and again, and you see that the patient is still in shock, that means it's bleeding somewhere. You have to take it up for an open surgery or any other interventions or like radiation, intervention radiology, where you can identify the bleeding vessel and stop the bleeding. They have to be stopped immediately if the patient remains in hemodynamic instability in spite of all your resuscitative methods. Tranexamic acid of late has been, studies have been done in head injury, but even for other injuries where we think that you need to, especially when it's sent from a peripheral center to the hospital, tranexamic acid 1 gram in 30 minutes might help the patient a lot if you think that patient will bleed a lot. This I already told. It's also important to make sure that you do a manual measurement of BP, the old BP cuff that will save the patient. Depending only on your automatic BP measurements, especially when the patient is in shock. If the systolic BP goes less than 90, the chances of an automatic blood pressure giving you a right estimate will be wrong. There is every chance that it will overestimate. Another thing is that most of the elderly persons or even young patients we have seen are on dual antiplatelets, there might be on warfarin and so many other things. We should have some idea about the reversal of the anticoagulation when there is a life-threatening hemorrhage in adults with trauma. So after assessing the airway, breathing and circulation, then comes the disability and the neurological effect. Perform a neurological evaluation. This can be done in the previous setup also. When you are going to intubate a patient, if the patient is going to be sedated or paralyzed, make sure that you do an evaluation of the neurological status. Don't stop at just the GCS alone. Look at the pupils. It can give a clear-cut idea whether the patient is going to crash. It can give any idea whether there is raised ICP because of intracranial bleeding, etc. And also measure the sugars, especially elderly. Make sure that the sugars are measured and the correction is done immediately. Always what we see is any head trauma, the drug that is given is mannitol and Rexona. Please try to change it to tranexamic acid, adequate analgesia. Patients are never given any analgesics if they are in severe trauma. And make sure that the airway is maintained in such patients. Coming to exposure, why is it important? You have to make sure that the patients are completely exposed and look for any signs of external hemorrhage and other signs of trauma. Missed injuries always pose a grave threat, especially the back. Sometimes it might not be considered at all. There could be penetrating injury in the back where it could bleed profusely and the patient could die on the way. And again, hypothermia should be prevented. Hypothermia contributes both to coagulopathy and the development of multiple organs. And so I'm going to details about that in the next few slides. There's something called the triad of death, which we have heard a lot. It consists of coagulopathy, acidosis, hypothermia. And look at it. Who contributes to most of it? When you give fluids, which are not warm, what is the temperature that you give the fluids at? It's usually 25 degrees Celsius maximum, right? And that there we are contributing hypothermia directly by ourselves. So when you give fluids, make sure that they warm up. And look at coagulopathy. You give 2 to 3 liters of fluid when the patient is continuously bleeding one side. You're all diluting the blood so much that we are actually contributing to the second most important part of the triad of triad of death in trauma, that is coagulopathy. The other one, basically because of blood loss, acidosis, which we might not be able to prevent unless we can start with blood transfusion as early as possible. The most important part is do not delay patient transfer, especially when there is a sign of head trauma. Getting a CT without a neurosurgeon in place, what does it do actually? It doesn't do anything. A lot of time is lost because of that. And in between, when the GCS goes below 8 and the patient is not intubated, they end up dead when they reach a place where trauma can be managed. So there are a lot of studies that mortality was higher for non-transferred patients compared to those who were transferred or treated at level 1 and level 2 trauma centers. That's all for this, and it's open to discussion that might lead to more points.
Thank you, Dr. Jinesh, for the wonderful presentation. Our topic is open source. What else?
If you don't have any questions, shall we move to the next slide? So the take-home message from my presentation will be: immediately try to secure the airway. Consider C-spine immobilization and not assessment when the patient is in polytrauma. Identify and treat, sorry about the spelling, tension pneumothorax immediately. Hemorrhage control in the patient who is in shock is paramount. Just giving bloods and fluids is not enough. Avoid too much fluids. O negative is not always negative. So it can be positive at times, especially in patients who are bleeding profusely. In pregnant females, O negative could be the choice of resuscitation. Avoid unnecessary medications. Try to give some medications that is useful to the patient. Control pain immediately and transfer the patient immediately to the trauma center. Thank you.
That's a good shot. So, Shruti, please have some love. Can you add something? Yeah, he's in emergency. A few words. Shruti.
That's a very important treatment to be person. So, as you can feel,
Basically, that topic is slightly different. That's basically triage. So there is a possible triage where immediately patient for life-threatening injuries in the hospital level. So the patient will be coming one by one. So you come to a large number of patients who are coming with trauma, and there are huge number of people are involved. There is something called mass casualty triage. What we give based on the resources that we have, we give importance to the principle called do the best to those people who are potentially survivors. Like if you have a patient who is severely injured and has no chance for survival, and you don't have enough equipment or resources for that, we have to try the second category until the resources are right. And we have to look for it. Let's see potentially survivability. So there is something called this type of practices that it is simply called we want people sort of patients like we want those who can walk based on the resources and they will be treated as minor patients. Those who can train, those who will be those who are still will be assessed immediately for some life saving something like that. If those survivors, they will be after and other categories considered to be immediate form. So they will be divided into immediate category, immediate category, etc. That's what we call it mass casualty triage. This is very specific system. The principles of management of trauma is what are we?
Around 2015, died last week. That is very good. I think that we have for equally transfer. Persons who are doing all these things. So, as I told, regarding multi-casualty and mass casualty, I had an experience from Singapore. In Singapore, government was SGS, Singapore Government Hospital. It's one of the best institutions in Asia. With a very big powerful system. So another was good. And just shown me on liver. If you put this liver, curtain will be coming from your brain and it will be divided into 50 rooms. The flash can be affected, and for each area, the way between the pipe and water, especially chemicals and so my concern is very important that all CMOs are and very staff nurses. They don't transfer. So the key what is lacking in especially in India. Also, they I get them. Or something after writing this CMO, see does it get easily get so time idea is actually we have to conduct this with extensive program. Either it may be cases or it may be basic program. With the initiation of IMA, then only this just like safety, life safety. Initiation and can realize that the very good team is the ASTER same team can be used for training everything that will reduce the as thousand people died of pedestrians accidents last 1 year. It's a very important
Next is the honor birthday is we had the success of our birthday. I invite all the you may appreciate the work they have to supporting the program. So I invite Goya sir to our venue. I invite Nina, the president of the secretary, to give the documents.
Senior members, senior members and friends, it's a great honor and privilege to talk about an upcoming personality in the entertainment industry. You might wonder, Dr. Ranjit C has changed his profession. Truly so, he is more known as a person in the entertainment industry. Since he had his debut as a music director in 2006, he had a debut. I remember that release in Sadhu, big release. Since then, he's going on with music, lot of advertisements, lot of the skits which he has been helping us since many years, not only for IMA, at the personal level for most of the doctors here. We know that how we perform, it's basically because of his skill. None of us are skilled. Absolutely none of us, except for probably Gopinath sir. He has got a talent by himself. He has just natural talent. None of us had any other talent. But it is the skill of this person to mold us into those specific characters which we displayed in many of our functions. And that was the ability of Dr. Ranjit. And we won't be surprised, he is going to be a big name in this industry. And he has got into direction of a movie and is in the advanced stage of it. I wish each one of us pray for his success in this industry. It's purely out of passion and not out of money, I presume. It's his passion because he's not trained in anything, either in music, either in direction, acting, nothing. He's a trained dentist and he doesn't do any dentistry as of I know. He has got a clinic in Cherur. He goes there only
busy practitioner.
busy practitioner other than dentistry.
Slow assistant.
When he gets bored, he goes and plucks one teeth and that's it. He's fine with that. So such a busy person, and next month he's going to launch something which is unique for KANNUR. It's telling the story of KANNUR in a song, which he has done right from scratch. Music, direction, many things. It's around, it will be launched next month. So we can be proud of that also. So ladies and gentlemen, once again, on behalf of IMA, personal behalf, Dr. Ranjit is a personal friend of mine also. We wish him all success in his passion. And I wish most of us know about his troupe also, music, black and white. And once in a while he brings out a program of nostalgic songs. Really wonderful, highly professional. So we wish him all the very best in his future endeavors, and we will give him all the support from our side. And I'm sure he will be helping us in the future, despite being a successful director, music director, and also a singer. Thank you very much.
Respected senior members, my dear friends, good evening to you. First of all, let me thank the organizers for inviting me here. Thank you very much. Instead of thanking me, I think I should thank you for giving me a chance to associate with IMA and work with such loving members of IMA. I really miss it. എനിക്ക് തോന്നുന്നു ഞാൻ കഴിഞ്ഞ ഒരു മാസം സ്കിറ്റില് 18 members ആണുങ്ങളെ സ്കിറ്റില് ഫീമെയിൽ സ്കിറ്റില് 10 members പിന്നെ മ്യൂസിക് ഫ്യൂഷൻ 5 പേര് അങ്ങനെ 35 പേര് ഓൾമോസ്റ്റ് എവറി ഡേ 6 o'clock എന്റെ വീട്ടിൽ അത് ഓരോ ബാച്ചായിട്ട് അവസാനം തീരുന്നത് 11 പക്ഷെ ശരിക്കും ഐ റിയലി മിസ് ദോസ് ഡേയ്സ്. എനിക്ക് തോന്നുന്നു ഞാൻ ഇപ്പൊ ഈ ലോക്ക്ഡൌൺ കഴിഞ്ഞതിന് ശേഷം എന്റെ ഒരു അവസ്ഥ ഈ അമേരിക്കയിലെല്ലാം മക്കളുള്ള അച്ഛൻ അവര് സാധാരണ ഈ മക്കളും മക്കളെല്ലാം കൊല്ലത്ത് 2 കൊല്ലത്തിന് ശേഷം എല്ലാവരും വരും. വന്നതിന് ശേഷം ഒരു 2 ആഴ്ച നിന്നിട്ട് തിരിച്ച് പോന്ന മുതൽ അവരൊരു നോൺ ഫീലിംഗ് അങ്ങനത്തെ ഒരു അവസ്ഥയാണ്. അതേ അവസ്ഥയാണ് ഇപ്പൊ. കാരണം 35 ആൾക്കാര് ദിവസം വന്ന വീട്ടിൽ ഇപ്പൊ ആരും അങ്ങനത്തെ ഒരു അവസ്ഥ. So we're waiting for the next program. പിന്നെ എനിക്കൊരു കാര്യം പറയുന്നത് ഡോക്ടേഴ്സിനോട് സാധാരണ രോഗികളുടെ രോഗം നോക്കുന്നു, പക്ഷെ സ്വന്തം ആരോഗ്യം നോക്കാത്ത ആൾക്കാരാണ് ഡോക്ടേഴ്സ്. അവര് പലതും അഡ്വൈസ് പേഷ്യൻസിന് മര്യാദ ഭക്ഷണം, കറക്റ്റ് സമയത്തിന് ഭക്ഷണം കഴിക്കണം, ഉറങ്ങണം, കറക്റ്റ് ഉറങ്ങണം. പക്ഷെ ഇതൊന്നും ഫോളോ ചെയ്യുന്ന ആൾക്കാരാണ്. എനിക്ക് തോന്നുന്നു 99% ആൾക്കാർ അങ്ങനെയുള്ള സമയത്ത് എനിക്ക് തോന്നുന്നു ഇങ്ങനെയുള്ള ഈ കലാപരിപാടികൾ, അതിന്റെ റിഹേഴ്സൽ, അതിന്റെ ആ ഒരു ഹാപ്പി ടൈം, അങ്ങനെയുള്ള കാര്യങ്ങളിലേക്ക് വന്നു കഴിഞ്ഞാൽ ആ റിലാക്സേഷൻ നമ്മളിപ്പോ ഓൾറെഡി നമ്മൾ കുറെ ആൾക്കാർ ഇനിയുള്ള എന്റെ ഒരു ഇനിയും പല ആൾക്കാരിലേക്ക് വരണം, ഇങ്ങനെയുള്ള പ്രോഗ്രാംസ് പുതിയതായിട്ടുള്ള ആൾക്കാർക്ക് വരണം എന്നാണ് എന്റെ ഒരു അഭ്യർത്ഥന. Anyway, thank you very much for the song. ഒരു കാര്യം കൂടി ഞാൻ മുരളിയുടെ നേരത്തെ പറഞ്ഞ മതി, കണ്ണൂരിന്റെ സൗന്ദര്യം ശരിക്കും ആസ്വദിച്ച ആൾക്കാർ കണ്ണൂരുണ്ടാവും. കാരണം കണ്ണൂരിലെ എല്ലാവരും അറിയുന്നത് പയ്യാമ്പല ബീച്ച്, കുഴപ്പലങ്ങാട് ബീച്ച്, കോട്ട, വളരെ ചുരുക്കം വരെ കണ്ണൂരിന്റെ സൗന്ദര്യം ശരിക്കും കണ്ടു കാണും. ശരിക്കും കണ്ണൂരിന്റെ സൗന്ദര്യം എന്ന് പറഞ്ഞാൽ ഔട്ട്സ്കേർട്സ് ആണ്. അതായത് കണ്ടൽക്കാട്, പുഴകളിലൂടെ തോണിയിൽ സഞ്ചരിക്കും. അപ്പോഴാണ് ശരിക്കും കണ്ണൂരിന്റെ ബ്യൂട്ടി കാണുന്നത്. അപ്പൊ അതില് ശരിക്കും പറഞ്ഞാൽ മലേഷ്യ, സ്വിറ്റ്സർലാൻഡ് പോലെ സ്ഥലങ്ങൾ കണ്ണൂർ നമുക്ക് ഇവിടുത്തെ ഒരു 10-25 കിലോമീറ്ററോളം യാത്ര ചെയ്താൽ പോകാൻ പറ്റിയ സ്ഥലങ്ങൾ. അങ്ങനെയുള്ള സ്ഥലങ്ങളും കാര്യങ്ങളും എല്ലാം ഞാനൊരു സോങ് ചെയ്തു. അതിന്റെ എഴുതിയത് തിരുവല്ലയാണ്. പാടിയതും അഭിനയിച്ചതും ദിലീപ് ശ്രീനിവാസൻ. അതിന്റെ മ്യൂസിക്കും ഡയറക്ഷനും ഞാനാണ് ചെയ്തത്. അത് സെപ്റ്റംബർ 4 നായനാർ അക്കാഡമിയിൽ വൈകുന്നേരം 6 അത് റിലീസ് ചെയ്യാം. അപ്പം എന്റെ പേഴ്സണൽ ഇൻവിറ്റേഷൻ അപ്പം ഇതില് നിങ്ങളുടെ ഗ്രൂപ്പിൽ. അപ്പം എല്ലാവരും വരണം. പ്ലീസ് സപ്പോർട്ട് മീ, പ്ലീസ് ബ്ലസ് മീ. താങ്ക് യു. അതിലെ ഈ ചെറിയൊരു കണക്ഷൻ ഉണ്ട്. മുഖം കാണിച്ച കുറച്ച് ആൾക്കാർ അയ്യപ്പനുണ്ട്. ബിനു, ഡോക്ടർ വിമൽ, ഡോക്ടർ ഹനീഫ, പിന്നെ പുരുഷോത്തം, അങ്ങനെ കുറച്ച് ആൾക്കാർ കൂടി ഉണ്ട്. ഓക്കെ, താങ്ക് യു വെരി മച്ച്.
Secretary,
Good evening. On behalf of KANNUR IMA, I extend my sincere thanks to our guest speaker, Dr. Jinesh, for his excellent talk on trauma care. Thank you, sir, for imparting basic knowledge on trauma care, which will be helpful for all the practitioners. And next, I would like to thank the man behind our great Doctors' Day celebration this year, Dr. Ranjit, for accepting our invitation and coming here and raising this occasion, and also accepting our token of appreciation. Sir, your dedication, your passion, your ideas, your sincerity, everything has surprised all of us. Without you, this Doctors' Day program was never a success. This much successful, it cannot be this much successful. And I hope and wish more and more such occasion to come, and wish all the success in all your future programs also. Thank you, sir, for coming here and raising this. And I thank all the members for coming and gracing this occasion of honoring Dr. Ranjit in spite of this heavy rain. Thank you. Thank you all.
Facebook